streamline everything. We give you the core stuff that you need, high yield, high impact, stratified, summarized. I actually wish somebody did that when I was a registrar, because I would have loved that. And so I'm trying to do this to empower others. I think this is designed to empower and to motivate everybody.
Yay! It's a Saturday morning, colleagues. Good morning, and how are you doing? It's such a great honor to host you. I want to mute the volume of my backup gadget because I'm getting a lot of feedback. Yeah, this is us, the clinical care platform. We are always so excited to host you because we are all about professional development. Whether it's a Saturday, whether it's a Monday evening, we are so happy. Whenever we get a chance to add value to your lives, I mean, what else can we ask for except to be very grateful, and also to appreciate the opportunity you have given us to be responsible for your continuous professional development. As always, I'm never a lone ranger. I am with our doctor of daily jokes. He's got an awesome PhD in that space. So, in addition to helping you grow professionally, I'm hoping that if you are going through something, maybe it's not a great morning, maybe it was a very difficult week, because we are always going through something through various, should I call them jokes, or inspirational statements. We would want to really make sure that we leave you uplifted. Yeah, so today we are hosting the Masters as part of the FCP Part 2 program. This is our final one. It's been a journey, and it's not possible without you, but also it's not possible, without our collaborators like Dr. Ranswe Pesat. From an administrative point of view, this is a paid event. And if you have paid, you have registered, you will receive your completion certificate if you attend adequately. Your CPDs would also be logged with your professional counsels. Should it happen that you are not able to complete this in time for whatever reason, maybe you are on call, etc., every person who has registered will get access to a self-paced version, either to complete the program or as part of your revision, pause, fast forward, etc., etc. So I hope that you would find today's educational moment to be fulfilling. I won't waste a lot of time. We already know Dr. Ranswe Pesat. He is a physician himself. He has gone through the FCP program, and he would have wished that I was there to do this coaching so that he could probably focus on the clinical work and everyday calls and family issues, knowing that there is this great mentor, Dr. Mao. But unfortunately,
Yay.
I was not there. But I think after today, I can try to start to coach. Colleagues, let us warmly welcome Dr. Ranswe Pesat. And as he comes on board, I also want to say thank you to yourselves for always trusting us with your professional development. I see there Dr. Bavich, Diduetsang, Florina, Laurent, Mangaliso, Nandip. I can't call all of you. Netu John, Santos, Sianda, just to say you are welcomed, and let us share this weekend with yourselves. Thanks, Brother Ryan.
Hello, brother. Hello, everybody. Warm welcome. Thank you for those words of encouragement and welcome. Hope everybody is good. I have a bit of a problem today. Apparently, some chaps where the municipality was digging the ground some place, and they interrupted the fiber. So I'm actually running off mobile data because they say that the repairs are in process and they don't know when the fiber is going to come back.
Mm.
So I just put my video on temporarily to say hello to Brother Mawela and everybody. And I'm going to switch my video off, and then we're going to proceed. Please forgive me if there's some interruptions in the signal, etc., because it's going to be a bit of a challenge today. But so far, so good. We're trusting God that everything's going to work out well. And I hope you're having a great morning. So this is me saying goodbye from the video. And so it's just my screen, right? Can everybody see my screen and hear my voice? Give me a thumbs up.
We can see it.
Novella is playing drums now, eh?
I'm no longer a DJ.
Yeah, now you're a drummer.
Yeah.
Okay, everybody. Okay, so I think we're ready to start. And let me just get my pointer in. Yeah, so FCP Masterclass, Dermatology. This is the 8th in the FCP series, and it's the 12th Masterclass we offer in internal medicine. And I'm so happy, I'm so glad, so excited to be here and to be collaborating with Brother Mawela. And yeah, I hope this is going to be a fruitful one, everybody. I do understand that exams have just happened and that people are probably a bit fatigued from the exams. So big thank you to whoever is here. Nonetheless, we are pushing on. This is the game plan, everybody. So there's 4 parts to today. So part 1 is going to be the theory, followed by OSCE. And then, I included this in the last 2 master classes when we go through common exam scripts. Because, what I've found is that some registrars, they have a wealth of knowledge, but they don't know how to answer questions. Like, there's a technique to actually answering questions in terms of how you sift out what the concept that is being asked is. So your ability to be able to spot buzzwords and spot exam scripts is important. So that actually helped you to answer the question correctly, right? And we're going to go through the technique of answering MCQs, and we're focusing just on neurology there. And then we'll go into the SOE component, right? So I'm sure you guys are familiar with this. This is the format, essentially the format that we've been using in the past 7 master classes. So with the addition of probably part 3, which is relatively new. Okay, so are you ready? Give me a thumbs up if you guys are ready. We're gonna start digging in. Uh, yeah, I hope I can see some thumbs there. Yes, I like the thumbs. I like the thumbs. Okay, part 1, theory. Neurology. We're starting with neurology. Now, in the previous masterclass, I started with the exam scripts, but I think this time around, maybe it's probably best to start with the theory because of the technical nature of some of these topics. Okay, so this is what we're covering, right? Neuromuscular junction disease, peripheral nerve and back pain, muscle disease, so myositis, myopathy, and that. Motor neuron disease, the poster child is amyotrophic lateral sclerosis. Vertigo, movement disorders with a focus on Parkinsonism, headache, epilepsy syndromes, seizure disorder, stroke, dementia, multiple sclerosis, okay? So let's get going, everybody. Starting off with a poll question. So you have this 33-year-old female who comes in with ptosis of the left eye. On examination, she has dysconjugate gaze that's worsened with fatigue. Now note a couple of buzzwords here, right? Ptosis, number 1. Number 2, dysconjugate gaze. Number 3, worsens with fatigue. Okay, these are all important into the context of the question. She also has weakness of the proximal arms and legs. So that's the 4th big clue. On examination, her sensation is normal. This is a beautiful statement to make. Her sensation is normal because this rules out some other pathologies, doesn't it? Reflexes are 2+. There's no dysmetria. There's no ataxia. So this essentially rules out cerebellar issues. Okay. I think I've got this is a video. So feast your eyes on the video. I'm sure you can appreciate the ptosis that's happening on the left eye. Then we have the infamous ice pack. So you note how it looked like she was snarling there for a second. That's what we call a myasthenic snarl. Okay, so you put the ice pack on, you wait a couple of seconds, and oh, sorry. Okay, well, there should be improvement in the ptosis. Okay, so the question goes on to say, which is the test that's most likely to be abnormal in this patient? You got option of 4: MRI brain, CT chest, CT abdo, MRI C spine. Now, I think feel free to type in the chat box, everybody. A, B, C, or D. I'll give you guys about 30 seconds. You can key in your answer, and then we can take it from there. All right. Hello, John and Florina, and Mashallah, and Neo, and Charlize Einberg, Nandipa, Lord. Nice to have you on board, everybody. Please forgive me if I mispronounce, like Brother Mawela says. Sometimes, our pronunciation is not on point. Sianda. Hey, Majek is back. Hello, Sianda. Yeah, so the overwhelming majority here is B. We got one A. We got a couple of A's actually, but overwhelmingly B. So nobody likes C. Oh, well, okay. Santos says D. Hello, Santos. Okay, Santos is in with D. Okay, interesting, right? So, okay, let's look at this. This question assumes that you know the diagnosis is myasthenia. So what would be like a diploma level question is to say, what is the diagnosis? But this is registrar level, so it assumes that you put the pieces together and you know this is myasthenia. So instead of asking you what's the diagnosis, they're asking you what test is most likely to be abnormal, okay? And we know that it's going to be the CT chest, okay? Why CT chest? Because of the link between thymoma and myasthenia, right? So part of the workup for myasthenia is looking for thymoma. To evaluate for thymoma, you get a CT chest. MRI of the brain would be helpful in certain cases, but not in this particular presentation. CT abdo is not indicated at this point, and MRI of the C-spine is not part of the workup for. So guys, let's zoom into myasthenia gravis. What are the key clinical points for myasthenia? Well, you can have either ocular involvement, bulbar involvement, which implies cranial neuropathy, or you can have the above. Now, proximal weakness in the upper extremities or in the lower extremities. And this weakness that we speak about, sorry guys, let me just move this. Yeah, this weakness that we speak about is oftentimes very fatigable. So fatigable is the key word you're looking for. So the evaluation of myasthenia involves blood work and antibody testing. We're looking for binding, blocking, and modulating antibodies. Now, if these are negative, then further testing could include antibodies for our muscle antibodies. Now, in the outpatient world, we can also coordinate EMG nerve conduction studies where we look for a decremental pattern. We talk about also evaluation to rule out thymoma. And thymoma is seen in up to 10% of cases of myasthenia, right? So not overwhelmingly common, but there is a link. So it's important to know. Because remember, this was the basis of the question that we just posed. The treatment for myasthenia gravis includes supportive treatment and also long-term management. The go-to therapy is our good friend pyridostigmine, as we know. For long-term management, patients can be on steroid or non-steroid, which is steroid-sparing regimens. These can be oral or intravenous. For acute exacerbation, in inpatient treatment may include plasmapheresis or intravenous immunoglobulin. We know that to be polygam. Obviously, if there's thymoma, you want to refer to for surgical evaluation. The non-steroid so-called sparing agents, other immunosuppressive therapies are listed here. Things like azathioprine, MMF, etc. Right. So this is your snapshot of myasthenia gravis. Now remember, guys, that we are not neurologists; we are physicians. Okay. So in light of that, you have to know these conditions, know the basics of management, know how and when to refer. But we don't like get into real depth about the studies, etc. Because neurology is not our passion. We are just physicians who need to know when to refer to neurology. So we're not going to do this stuff in any great depth. Okay, I'm just giving you enough that you need for physician exams. Okay, now here's an example of what you would see on outpatient evaluation with neurodiagnostics. This is a repetitive stimulation nerve conduction study, and you would see the decremental pattern here, right? So obviously now this is not probably tested, but I think it'd be unfair to ask this in a physician exam because nerve conduction really is the domain of the neurologist and the neurophysiologist. Okay, so a cousin of myasthenia, I'm sure you guys know, is the infamous Lambert-Eaton syndrome. So myasthenia gravis is part of neuromuscular junction disorders. It's on the presynaptic side. So what's the pathophys? Right? There's antibodies against the postsynaptic acetylcholine receptor. That's myasthenia. But Lambert-Eaton is on the presynaptic voltage-gated calcium channel receptor, right? Lambert-Eaton is actually seen with paraneoplastic syndrome. So you gotta know the link between Lambert-Eaton and neoplasia. This is a paraneoplastic manifestation. Most commonly, the culprit is the naughty small cell lung cancer. And we know small cell is also associated with lots of endocrine paraneoplastic manifestations, which we're not going to get into right now. But the key features of Lambert-Eaton are similar, but they're somewhat different. So they're similar in that they NMJ and they have proximal involvement, but they different. You see, the fatigability is usually not a feature of Lambert-Eaton, whereas fatigability is big with myasthenia. It's not really big with Lambert-Eaton. And patients actually may get what they call facilitation with exercise, where repetitive contraction of the muscle actually improves the weakness. The reflexes in Lambert-Eaton are also hyperreflexic. There's also more autonomic manifestations, dysautonomic features like dry mouth, blurred vision, constipation, impotence, and that. So remember here, we said the involvement is not postsynaptic, it's presynaptic calcium channel antibody. There's also an increment, not a decrement, an increment on repetitive nerve conduction stimulation. And to clarify, Lambert Eaton is actually on the presynaptic side, right? All righty. Here's the case discussion. 25-year-old male comes in with acute dysphagia for the past 2 days. He was found to have ophthalmoparesis, bilateral ptosis, proximal